Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Jill Schaffeld, your host for today. Today's discussion is on depression and depression assessment, as well as different ways to think about and manage depression in the primary care office. So today I'm excited. I'm in the studio with two of our experts, Dr. Landon Krantz, who is the mental health lead for Cincinnati Children's Primary Care, as well as Dr. Rachel Herbst, who is with clinical psychology or behavioral medicine, in clinical psychology, and the director of the Integrative Behavioral Health and Primary Care Center at Cincinnati Children's. So welcome to you both, and thanks for joining us today. So I'll actually start with Dr. Herbst. Do you mind to share just a little bit about yourself, maybe how long you've been practicing at Cincinnati Children's, any special interests you might have?
Sure. I have been with children since 2016. I was actually recruited to start our integrated behavioral health program in primary care. And what's exciting to me is that was part of the strategic plan for 2020 to look at the reduction in bending the curve of mental health diagnoses. And so I actually specialize in infant mental health, which many people don't even know exists as an area to specialize in.
That's cool.
And so I focus on kids from birth to 5, but I have expertise in the whole pediatric lifespan. And our goal is to be embedded within the academic general peds clinics and be available as we see opportunities to enhance social emotional health so we can prevent mental and behavioral health disorders, but also to be there to capture them early or to help collaboratively offer services within that primary care medical home. So I lead a team of psychologists, and we do a lot of medical education. I direct a rotation regarding that. So it's really exciting to think about reaching a broader audience, and it's been wonderful to partner with Dr. Krantz in all of these efforts.
Well, awesome. That is a really interesting background, and I love that, and it gets me even more excited for what we're going to focus on today, which will be a little bit about assessment, but diving into some very just even non-pharmacological ways of treating depression, and really shows what a wealth of knowledge you should have, because obviously birth to 5, we're not doing medicines for, therapy
exactly.
for those.
And we're thinking about caregiver mental health.
Absolutely.
So, thinking broadly about this applicability, given that, in peds we care about the family system. So
Wonderful.
Even though we won't talk a lot about caregivers, these things that we're going to talk about today are going to be applicable to them as well.
Great. Love it. All right. I apologize, Dr. Krantz. You have to follow up that big introduction, but no, I'm just teasing. So, but thank you for joining us as well. And if you could share a little bit about yourself as well as just how long you've been practicing here, some of your special interests, that would be wonderful.
Sure. Yeah, and in school I always like to present first because that sets the bar and I don't have to follow. That was my strategy to get me through a lot. But so I'm Landon Krantz. I'm a general pediatrician by training. I finished residency here at Cincinnati in 2017 and then went into private practice up in Wisconsin as part of Children's Wisconsin, very similar to the CHSN set up here for 5 years. And with COVID, with a lack of child psychiatrists, with a mental health crisis going on, I just became very interested in mental health care, sought out some extra training as a pediatrician, served as the primary care representative for the state consult service. So that was run by psychiatry, and there is one coming to Ohio now, and was the primary care rep there. And then got very interested in public health, so came back to Cincinnati in 2022 to do an academic fellowship. Most of my research was around suicide prevention, and now back in clinic doing other mental health work. And I would say my focus, because of my background in practice for 5 years, I'm really interested in bridging the gap between the academic world and the clinical world. I really love talking about implementation. I love talking about QI. And I think it's great that we have all this data and all these numbers and all these statistics. But for me, it's always like, what does that look like in practice? What does that look like when a physician is talking to a parent and an adolescent in that room? Because it's sometimes very different. And so that's where my mind always goes. So whenever I think about these recommendations or what we're talking about today, I'm coming from the perspective of what's practical to make a real impact, and not just something that is kind of,
statistically
edible.
significant,
Yeah.
but not really clinically significant.
Statistically significant and not clinically doable either. If I told you to do a 220 question screener and you'll prevent all
Absolutely.
suicide, that's wonderful, but it's probably not going to happen. So.
Right. No, I love that. And, it's interesting when we do a lot of these and we have our experts come on, and I love having another general pediatrician here who really does understand, day to day what it's like seeing patients in the office, and to be a wonderful kind of ally as well as an expert on the topic to help us learn how to integrate those things into our daily practice. So that's wonderful. Awesome. Well, thank you both for being here. Let's go ahead and jump right in. I'd like to just touch a little bit on assessment. So definitely different tools out there for primary pediatricians to use. I think one of the more common ones that we see now that's typically used for screening would be the PHQ, specifically PHQ-2 and then PHQ-9. And I believe the AAP recommends annual screening for ages 12 and older for risk factors really if there's risk factors at any age. So screening just 12 and older no matter what. If and either one of you, feel free to take this question, but do we feel like how good of a tool is the PHQ? Maybe what are some of its downfalls? And then any new screenings that, have maybe gained a little more popularity for good reasons, right? For, to help these populations in our office.
Okay,
Yeah,
go
absolutely. So the PHQ-2 is a great tool to get that first pass to say, like, thumbs up, thumbs down, are we worried about depressive symptomatology? And then what's nice about the PHQ-9, which is really what should be administered if the PHQ-2 is positive, is that it aligns well with SIGI caps and other, diagnostic criteria in the DSM. So it gives you a really quick read on whether those depressive symptoms are present, and also the level of potential impairment ranging from mild to moderate to severe. One of the limitations, which I think a lot of folks aren't really aware of, is that the final question that asks about suicidal ideation is not the most robust indicator of whether or not we're concerned about potential suicidality. So when we look across a variety of different research studies, its predictive ability is really subpar. And as we're moving into this space of thinking about, zero suicide initiatives and other things, we know that we're missing the gap, and that suicidal ideation doesn't only exist in the context of depression. So if we're only using the PHQ-9 and only relying on that final question to give us a sense of concern about suicidality, we're really missing the mark. So one of the tools that's been around but has started to gain more popularity and more use, and we've incorporated it within the last few years within the academic medical Gen Peds clinics, is the ASQ, or the Ask Suicide Questions, and it's a 5-question measure that has much more reliability and validity when it comes to assessing for suicidality. And given that the stakes are high when it comes to suicidality, we want to make sure that we've got the most sensitive tool to be able to help us get a sense of that. And I would say in practice, we see all the time where there are kids that, historically had completed the PHQ-9, we had no concerns about suicidality, and then we give the ASQ and we actually realize there was past ideation, or maybe there was a past attempt that nobody knew about. And so it's wonderful that we now have this tool, and it's not a heavy lift of 5 questions to get a better sense of what that current risk status is, what the historical risk status is, and then to be able to have a more tailored approach to how we want to manage that information that is gathering.
I've got the data. I have or as the kids say, I have the receipts. So there was a large study for adolescents that combined the PHQ-9 with the ASQ, and found that 8.3% of cases that were missed. So in a sense, they got another 8% of suicide risk. So these are kids who had normal PHQ-9s and yet were positive on the ASQ for suicide risk. So if you think about the amount of PHQs you're doing in your clinic over a week, over a month, over a year, you might pick up on another 8% of kids at risk. And then a study that came out last week found that children with depression, so this isn't for screening, this is for adolescents with known depression, 30% of those that said none, not at all on question 9 had a self-harm episode within 30 days. I think it was 28 or
Wow.
29%. But those are kids with known depression.
Close to a third had
Yeah,
it
so-
in 30 days, too.
Yeah, I'm
That's
double checking.
impressive.
We can edit, so this
No,
long
that's
pause.
okay.
Yes, so of the 691 adolescents who have depression and scored 0 on question 9, 29% or 197 of them had a self-harm or a completed suicide within 30 days of that 0.
Wow.
So the PHQ-9 is really excellent for picking up on depression symptoms, and the DSM-5 has 9 symptoms of depression, and it's PHQ-9, so you don't even have to memorize anything from the DSM. There's your 9 symptoms. But if you're really just wondering about suicide, that feels, as we do suicide research, suicide itself feels like a different ballgame, a different set of risk factors that the PHQ-9 just doesn't fully grasp.
Okay. Yeah. If that's not really concrete, good evidence to really, I think, show us the importance of the ASQ. So thank you. Gosh, thank you for sharing. Yeah, I'm a little like, wow. So, which is great.
And it's 4
that's
questions,
why we're doing this,
sometimes
right?
4 to 5 questions. It's pretty quick.
Do you want to share the 4?
So the Ask Suicide Screening questions, or the ASQ, not to be confused with the development ASQ. It is free on the NIMH.gov website under ASQ Toolkit. So the first question is, in the past few weeks, have you wished you were dead? In the second question is, in the past few weeks, have you felt that you or your family would be better off if you were dead? And we know that feeling like a burden to others is a enormous risk factor for self-harm, and so that question gets right to the heart of that. Number 3 is, in the past week, have you been having thoughts about killing yourself? And question 4 is, have you ever tried to kill yourself? And question 4 is the one that might be yes forever if you've had an attempt, and doesn't necessarily mean you have an imminent risk, but it's still an important question. And question 5 is, are you having thoughts of killing yourself right now? And one thing that I would point out that's notably different from this than the PHQ-9 is the direct language. Are
Absolutely.
you thinking of hurting yourself? Do you want to die? And if you read PHQ question 9, it's not as direct. And in fairness, it wasn't designed to be that way. The criteria for depression are thoughts of death, not wanting to kill yourself. And so it was designed to pick up on depression, and that's what it does.
Sure. But not
And
necessarily intention.
Correct.
Which
The
sounds-
language is
It's-
not ambiguous at all in the
No.
ASQ.
No. Wow. Thank you. Thank you for sharing that, too, because I think, this tool may be one that general practitioners and pediatricians aren't quite as familiar with. So I think, important that we were able to really understand what are these questions and how do they differ. So I appreciate that.
The only footnote that I would add to this is that the directness is intentional, and there's great, robust research to say that when you are actually assessing for or intervening, that it is important to be direct, but also that is a shift for a lot of folks where, oftentimes, people's verbal assessment of suicidality is, kind of dancing around the topics or softening, the discussion of what it is. And there is great research to say that when we really want to assess this and intervene on this, direct is best.
And it won't increase the risk.
Exactly. And asking in this direct way won't increase the risk. It won't make, people think about this if they haven't thought about this before. But I do think it can be a little startling if this is really
Sure.
different from, what you're used to with the PHQ-9 or what you would do verbally when interviewing a patient to try to get a sense of what their risk is. So I do just want to acknowledge that feels like a big shift, but it's an intentional one that we actually know has benefit to, detecting and intervening around suicidality.
I think that's a great point. I sometimes share with my patients when I do ask something that maybe does seem more direct and they're like, completely taken off guard. Sometimes that's a good thing. It's okay. I like that you had that reaction, that you were a little, because that either means that we need to talk about it or we don't, right? And that's okay. And it's also, I would argue that being direct, if someone has thought about those things, they're not always going to be shocked. They're going to be like, well, yeah, I have, versus, a complete shock, which it's okay. Like you said, these are hard things to talk
Right.
about, but it's okay to just ask and to know that you have, put that out on the table, and they know that, wow, you've already delved into that. Anything else I talk about from here on out will be maybe not easy, but it's fair game, right? It's
exactly.
okay
You've
to talk
validated
about
it,
those
and
things.
you've also modeled for that patient, for that family, that I am comfortable talking about this,
These
right?
hard things.
These hard things,
Yeah.
and that I'm going to be this sturdy leader and guide for you throughout this process, even if we all have these moments where we don't feel that way.
Sure.
We're communicating that to families that, this is something that falls within our scope of practice when we work in general pediatrics.
Absolutely. So, I wanted to just maybe touch on the Columbia Suicide Severity Rating Scale as well. We don't have to really delve into it, but how does that come into play? Is it a tool that is used in place? Because I do think a lot of general pediatricians are familiar with that. Is that a tool that generally would be used in place of the ASQ? Would it be used in conjunction with the ASQ?
Yeah, it gets very confusing, and I actually just learned more about it like last week, so
Well, great.
No judgment at all. I have learned that there are two versions of that, and so there is the traditional version, which is quite lengthy, which rates the intensity of symptoms. Is really kind of the gold standard for suicide risk and suicide assessment. And there is a shorter version that's, I believe, 6 questions that's very similar to the ASQ, and I would argue is interchangeable for a pediatrician. But just be careful when you Google CSRS, if you get like a 3 to 4 page descriptive question, that's the long one.
Okay.
And
There are actually more than 2 versions. So just
So
look
are
for
there?
yes.
Yeah, okay.
So just
So I'm
look
learning
for
more
the
today.
healthcare-
The
yes.
basic.
Yeah.
Look for the healthcare version.
What I
that
like,
is the
what I like
basic.
about the ASQ too is if you go to the toolkit with the questions, it has the next steps based on the questions right there for you. So as Dr. Herbst said, the daunting nature of these questions can be hard, but the ASQ toolkit gives you how to respond to the questions as a clinician.
Wonderful.
Which is nice.
Great. And thank you. I just wanted to mention that because I feel like it's another, we talked about the PHQ. Really seems like things are kind of leaning towards using the ASQ for multiple great reasons that you've shared. But I knew that would be another method of kind of assessing patients that maybe other pediatricians and physicians were aware of. So we're going to switch gears a little bit. So thank you for talking about kind of assessment and how to think about things in the office, and excited that our focus today is really not all on medicine, because I do feel like general pediatricians, depending on your training, maybe aren't always comfortable with, depression medications or just a few. And so the idea that that's number one, we can do so much more besides medicine, I think is very important. And two, just to know kind of how to implement those other things without just saying, hey, here's your referral to therapy. Things we can really tangibly do in an office setting. And so one really neat, I would say, thing that appeared in my office a few months ago, and, looked at it a few times and thought, well, this is neat, and now what do I do with it, is the Daily Mood Action Plan, which, just to share with all of our listeners, I think we will include at the bottom of the podcast page a link to the Daily Mood Action Plan so that you can look at specifically what we're talking about. But and either one of you is happy, I will be happy, I'm sorry, for you to jump right in. What is this? Why was it developed? And how do we use this? How can this help us as pediatricians if we're sitting in the office and we've done our assessment and we said, wow, we need to make some interventions here. We need to change some things. We need to really do things in the here and now and make a difference in what's going on.
Well, the development of it came, honestly, during a QI project to improve follow-up. So to improve engagement in the patient's engagement, the family's engagement in their mental health care, and to encourage them to keep following up with us and talking to us about how they're doing. The way it's structured is similar to an asthma action plan, and the reason we did that is because most pediatricians, again, thinking about the practical implementation of something, are familiar with an asthma action plan. So there's a green zone, a yellow zone, a red zone. And so we also found that many patients, not just clinicians, but patients aren't comfortable with medication. And I'll just throw out a quick disclaimer that I'm very supportive of using medication in the right circumstances, and that could be a whole nother talk. And this tool is not meant to replace medication in any way, But when there is that resistance or that hesitance, there's other things that can be done.
Or if it's, mild symptoms of depression where medication might not be indicated, that we also wanted options, which we'll kind of circle back to as well.
Yeah, and then I just wanted to hit on the green zone. To me was the most important one, because I think we focus a lot on those bad days or those really bad days and crises, and we wanted to communicate to our patients, hey, your good days, there's things you can be doing for your mental health as well. Mental health is not just treating illness, but promoting wellness. And so the green zone is an area that we spent arguably the most time on to really say, even on those good days or bad days, what can you be doing every day to kind of keep yourself in a good place? And so those are things that I feel any pediatrician can talk about, whether it's working on healthy diet, healthy lifestyle, social risks, drug, smoking use, and mental health.
Sure. That's a great point when you talk about the green zone, because that's what we are supposed to do as general pediatricians, right? Preventative care, prevent these things from being a problem. So to put as much or more focus on that, I think makes perfect sense, because the idea is to prevent those bad days. So that's wonderful. And I mean, looking at it, of course, and I'm sure you guys will be happy to share some of this, but moving your body, like you said, getting a good night's sleep, spending time with people we enjoy being around, friends, family, and then just keeping those routines, as well as other things like therapy, or if medication, was recommended, to do those as well. So, and really, this tool, if I'm correct, is supposed to be used kind of as a daily check-in.
Absolutely.
So do you recommend that patients, maybe pick a time of day, like every day before school we do this, or every day, at 5 o'clock, or how do you kind of get the buy-in from the patient? What are your recommendations for them?
So I think first about leaning really heavily into motivational interviewing. What's important about this for you, right? Like, why is it important for you to feel like your mood is in a good place? Or what are your other goals in life? Are they academic? Are they sports related? Are they friendship or family related? And then being able to use those goals and values to link to, great, those are things that are important to you. I want to help support you in meeting the goals that you've got. And we know that part of that is making sure that we're promoting your mental wellness. And so these are opportunities then for us to think about, which of these do you want to start with and prioritize? Where are you at baseline? Where do you want to go, right? So really thinking about that strong MI component of being able to tailor it to that teen, to that child, to that family. And then thinking about it like a SMART goal, where we really do want to get into a little bit more specificity about when is the best time for you? What do you want the role of your caregiver to be? What do you want your caregiver to not do so that you feel like you can continue to maintain this? And we know from all of the research around creation of habits that we need to sometimes also fake it till we make it, right? We need to get in the habit of doing the routine before we're able to see how it directly benefits us, right? 2 nights of good sleep are not going to make you super motivated to continue to prioritize your sleep hygiene. If anything, you might feel even worse because your body's not used to it. And so we want to spend that time and that priority around being able to establish this as a new routine, as a new habit. And I think both for the reasons that Dr. Krantz was talking about in terms of, that preventative aspect, but also if you do, or if you've had a history of depression or other mood disorders, then we know that you're at risk of having other episodes. And so being able to maintain things in the green zone are a great way to be able to prevent future episodes from their onset, or if and when they do onset, to be able to prevent the level of severity, be able to catch it early, and to be able to have this kind of cornerstone set of activities that are going to be part of the package, might not be the whole package, in managing those symptoms as they arise. And so, again, this is part of why we prioritize this area, because when you look at the research, which I am sure that Dr. Krantz is like chomping at the bit to be able to delve in more to, there's just so many ways to really understand the value of this. And I think exactly to your point, this is like solidly bread and butter, bright futures, focused, where it is comfortable for pediatricians to talk about this. They've already established their role and their expertise with families to be able to discuss these topics. I think the novelty is really being able to connect that to mental wellness, right? Oftentimes we're thinking about, sleep in terms of, academic performance or other, related benefits. Same thing with physical fitness. We're thinking about obesity prevention, all these other pieces. And hopefully this just helps kind of, nudge pediatricians to remember that this also is part of mental health, mental wellness. And so it's not novel. It's just a different way to think about the application of these, tools that are already well developed in pediatricians.
I love that, Pearl, you shared about the motivational interviewing. What are your goals? Like what, we're doing all these physicals this time of year, sports physicals and this. Well, let's talk about what is your main goal for the school year. And like you said, maybe it's friends, maybe it's sports, maybe it's academics, and saying, okay, well, let's talk about how we get there. And one of those things that's super important is your mental health, right? So tying that into something that they're really invested in, I think is a wonderful trick and a wonderful tool. So, yeah. Absolutely.
Yeah, and I liked how you mentioned, too, about mild symptoms. So sometimes we'll have a kid come in with a PHQ-9, and it's not quite at the level where we, jump to diagnoses or jump to, more aggressive treatment, but something just feels like we might be going down a bad path. And so what can you do for those mild symptoms? And you mentioned sleep. I wanted to stress again the importance of sleep from many different angles. Poor sleep is a risk factor for suicide. So we all know that when we're extremely tired or not sleeping well, our mindset is a little off. Maybe we're a little more impulsive, a little bit more emotional. So sleep itself is very important for people with mental illness. But also there's studies, and we'll tag them here to the podcast or attach them, that youth with sleep disturbances, they watch them for years. The ones with more sleep disturbance were more likely to have anxiety or depression.
Sure.
And that relationship was true for all kids, but it was stronger for females. And then another study looked at melatonin and found that kids looking at themselves before they were on melatonin to after melatonin, that there was a decrease in self-harm by 54%, so a relative risk of 0.46. So basically and again, the effect was stronger for females or for girls. So even something like melatonin might make a huge difference. And there were limitations to that study. We don't have to get into the nerdiness of my interpretation, but it's important to see that seeing someone with mild symptoms and developing a relationship with them, saying, hey, I care about your mental health, how about we just get a good night's sleep? And then repeating the PHQ-9 to see if you're getting better, getting worse a few weeks down the road. Honestly, I don't mean to exaggerate. I mean this seriously. That might save a life. So melatonin, good night's sleep when you're seeing mild symptoms might prevent something really bad down the road.
Sure, absolutely. So we talked to how a lot of time in developing the mood action plan was spent on the green section, but as we kind of progress on yellow, which is, I love that it shares kind of at the top, like, I feel tired, I don't have the energy I normally do, I feel irritable, activities that I usually enjoy are not making me happy, trouble sleeping, which you just touched on as a huge, huge indicator of issues, or just feeling overwhelmed. And that kind of goes through what to do on a yellow day, but it also talks about if you're doing these things and you stay in that zone for 2 weeks, you need to reach out to your physician. You need to reach out to your therapist, which I think is really important. Dr. Herbst, do you have anything to share in terms of specifics in the yellow zone or kind of ways to talk to our patients about what it means to be there, ways to hopefully help us get out of the yellow zone and avoid progressing to the red zone?
Absolutely. So the development of the yellow zone is really informed by some different CBT approaches. And what we know from cognitive behavioral therapy, CBT, is that when we're depressed, we start to get stuck in these vicious cycles. And the first vicious cycle is that we're more likely to pay attention to the negative things in our life than the positive things in our life. And we know that's well established as just an experience that is common when we are having depressive symptomatology. And then when we start to pay attention to that, then our mood starts to shift and our mood starts to change, and we start to see those symptoms of, irritability or sadness or emotional dysregulation that comes alongside with those thoughts of like, oh, this just sucks, nothing's going to change. And then we end up in this second cycle where we start avoiding things that we once enjoyed doing because we're like, why even try? It's not even worth it to play basketball with my friends because they don't really care that much about me anyway. And so we get stuck in these downward spirals, and that means our mood continues to get sucked down in those spirals too. And so really what's built into the yellow section is a strategy from CBT that for mild symptomatology can be enough of a therapeutic strategy on its own without the full package of CBT, and definitely falls within the realm of what a pediatrician can do. And the idea is that we want to be really intentional about activating our behavior to start re-engaging in these things that once gave us pleasure that we've started to avoid doing. And this, again, similar to the green zone, we want to use that same idea of SMART goals. Like, we're going to brainstorm together, what were things that you used to enjoy? It might be really hard to generate those. Can we think about that with a caregiver? Can I give some ideas? And they could be really small things. Is there somebody on TikTok that used to always make you laugh, right?
Sure.
It doesn't need to be anything that's really intensive or engaged. But again, we know as part of this downward spiral, you're less likely to be engaging in those things that are going to be good from a dopamine standpoint, from a serotonin standpoint. And so what we want to do is we want to start to activate that behavioral part of CBT so that then we're starting to change the mood from that. And so this is about really scheduling those activities in that we know have the potential to give pleasure and starting to be able to pay attention to how did you feel before you did that activity? How did you feel after? And so it's a way to really activate and break from that cycle of avoidance, withdrawal, and that negative spiral that comes alongside mood. And I think, one of the things that's been really lovely in resident training is as I've trained residents to do this, it sort of demystifies the idea of CBT. People are like, oh, I need to talk about, this model of how these things are all related, but then what do I actually do with it? And that's not mine. Absolutely, that should be separate in therapy that you're actually taking and implementing it. But I think people understand that there's this connection between our thoughts, our feelings, and our behavior. And normally we need to change our behavior first before our thoughts and our feelings start to change. And this is just a really concrete, tangible, essentially extension of some of the things in the green zone that can be done quickly and efficiently within that primary care visit. And also, if a patient needs therapy, is a great buy-in because it gives them a preview to say, let me take out the mystery, because many patients and families, their experience or their thoughts about therapy come from what they've seen in the media, which most of the time is still that you're laying on a couch and it's really inaccurate. Or it might have come from other therapy experiences that have been less active evidence-based treatments where I went to somebody, I talked about my feelings, they taught me a few coping skills, and it didn't really help. And so this preview coming from somebody that families already trust and know and can be started immediately, especially when we know that there are these long wait lists to get into therapy, are a really tangible strategy. And like I said, for some families and patients, this might be a sufficient standalone treatment. So
that's a great way to think about it, that this truly just, even these examples of things to do, that families, you can think of this as a therapy, right? It is an intervention that should help. And they're, just to share with our listeners a little bit, because I know they obviously can't see what I'm looking at, but watching a funny video, as you mentioned, a TikToker that made you laugh, hanging out with friends, going outside, listening to music, just moving your body, dancing, things like that. It's a really cool way, I think, to think about what you just said, that, hey, this is part of our therapy. And it's not, like you said, necessarily going to someone to just spill everything. Like, therapy should be thought of as, yes, if that's what you need, that's fine, but therapy is the behavioral interventions we're making too, and they don't have to be long and complicated interventions. They can be short, little things that help our mood.
And they should be tools that prepare you for life. Right?
Absolutely.
So whether that life is a life where you have a diagnosis of major depressive disorder and you're going to prepare that there are going to be other episodes where you're going to need to use this, or, a life that any of us live where we go through stressful times and we see changes in our mood because that's part of being human and living in the world. The other piece that I really like about this is that, the practice in which Dr. Krantz and I work, a lot of the families have complex psychosocial circumstances that increase their risk for depression, because if you are currently unhoused, or you're living in poverty, or you're facing racial discrimination, of course it's going to impact your mood. And also, given the historical biases and traumatic things that have happened in healthcare and in the mental health system, there is oftentimes hesitance to engage in certain treatments, and rightfully so. And what I love about these strategies is, it's really tied to this cultural responsiveness of these don't feel like such a huge leap. Right?
Absolutely.
These are things that, again, feel familiar to what's discussed in pediatrics all of the time, and they can be effective. And if you're on the fence for, a multitude of very understandable reasons, this is not such a big leap or such a big sell. And so one of the things that we both value is thinking about health equity. And, our patient population is far less likely to get engaged in therapy or meds for multiple reasons. And so that was another impetus as we thought about the mood action plan, is how does this have applicability, when we are thinking about these considerations that are different across, different patient populations. So that's the other thing that I think is really nice about behavioral activation, is it doesn't have, some of the vestiges of like stigma, or,
Absolutely.
Feeling like, oh, I don't know that I want to like disclose to somebody that I don't know well
Sure.
these things. Great. We don't even need to talk about those things. We just need to get started in making these behavior changes to improve your mood.
That's awesome. Well, and hopefully, with all the wonderful info you just shared, we wouldn't slide into the red zone. But as you said, life is hard sometimes. And so I'd love to kind of spend the last few minutes here discussing what the red zone of the mood action plan, kind of what it means, how to go about responding to that as a patient or as a physician with a patient who truly feels like they're in the red zone of the mood action plan.
Yeah, so the red zone is designed to model after a safety plan, essentially. So, there's plenty of safety plans that you could find online, and if you're comfortable doing those, great. This is another option. It's modeled off more serious risk factors for imminent self-harm or imminent suicide, which are under the symptoms for the red zone. And then it essentially is, it's time to get help right now and not wait. As a pediatrician, there's a range of things that you could do. I would say that the biggest takeaway that I have when I think about my patients going to the red zone, it's probably not going to happen in the office. It's probably going to happen when they're not, directly in my care. So the most important thing, not the most important, but one of the most achievable things for a pediatrician is means reduction. And so if you have an adolescent, even with mild symptoms, you never know what can happen the next day or 2 days later. Means reduction can be a tremendous benefit to preventing suicide. And so what I mean by that is lock boxes for firearms, for medications, access to lethal means being limited. About 40%, some would say 50% of suicide attempts happen within 10 to 20 minutes of thinking about suicide. So that's pretty fast. So you have the thought and then it happens. And so whatever you can do to make it harder to get to those means, whatever you can do to delay that moment, actually has a great, therapeutic clinical benefit.
Wow.
Because there really aren't as many people who are having that thought and then 2 hours later, attempting suicide. It's usually very quick. So I also tell my patients, I say, hey, if you're ever in this red zone, just remember right now you're not. And so this will pass. Let it pass. Do something to distract yourself. Create a barrier to that lethal means. Create a barrier to hurting yourself. And there's a really, I'm sorry for time, but there's a very interesting story. There was a bridge in Canada, I believe, and I'd have to look it up for the details, but it was known for being a place where people would jump and die by suicide. And they wanted to put nets up on the bridge to prevent people from hurting themselves and from dying. And about, a couple hundred feet away, there was another bridge across the river, and a couple hundred feet, there was another bridge, and everyone said, well, if you put up nets here, people are just gonna go to the other bridge. And surprisingly, they didn't. People would go to that bridge, they'd see the nets, they'd walk by, they'd make the long walk over, and the thoughts would pass. And so, there is something about suicide and suicidality that comes and goes, and whatever you can do to delay that moment is crucial. And the key of the red zone is it's not time to be alone. It's time to get help right now, and make sure they have the phone numbers and the contacts they need to get help in that moment.
Sure.
The other thing I would underscore is that, similar to the asthma action plan that this was modeled off of, everybody hopes that asthma is well managed and that you're not going to get to that severe level of exacerbation. But we still are accustomed to sort of counseling that if you get there, here's the guidance about what would happen. And I think that there's a lot of variability in practice right now of how frequently people are prompted when they're talking with patients that have any symptoms of depression to think about that. I think it's, really obvious and top of mind if it's like moderate to severe. But to Dr. Krantz's point, I think oftentimes for patients with mild symptoms of depression, that discussion is not as common as really what we would want it to be. And not to say that we need to spend a lot of time on that if we're seeing somebody with mild symptoms, but just, a brief sentence or two to acknowledge that it's here, and then to provide that additional support and reassurance to caregivers that this will walk you through exactly what needs to happen in the moment should you get to that point in time. And, we're doing all these things to prevent it. And at the same time, I want you to feel empowered that you know what you would do if this did arise.
Worst case scenario, that's great. Just to have that, to kind of feel that safety net and to feel that I know what I would do.
Yeah, about the parents. The biggest surprise I've had doing this action plan is I'll go over with the teenager, and then I'll be walking out of the room, and the mom or the dad or the caregiver will go, Can I have one?
Oh, sure.
Yes.
Do you have an extra?
Absolutely.
I kind of like having this for myself.
That's
so
great.
it really creates like a whole culture of mental wellness, and that there are going to be yellow days, but what can we do in those days?
Absolutely.
And we're decreasing stigma by naming that suicidality can happen in, times when we're not expecting it, or that the onset can be rapid, because most of the time, most patients don't hear any of their providers talk about suicidality unless they're in this small subset where there has been some significant level of risk.
Absolutely.
And just like we counsel about a lot of other things that are like low base rate in the community, but we still want to engage in safety practices, this is part of that too. And so that's the other way in which we're hoping the Mood Action Plan turns the tide of, stigma and provides that socialization of all of these things are things that fall within the realm of peds and that we should be talking about in primary care.
Yep, that's great. And I think the other thing I don't believe I already mentioned, and my apologies if I did, was we will have a list of apps that are kind of in our yellow action plan. One of the things that is mentioned on it, or our yellow section, is to use an app that's like a proven mental health app that would help teenagers. And I think we have a list of those that we will include.
Exactly. It's
at
on the
bottom
back side of
this,
the action
so.
plan for exactly that purpose, is to say, you might need extra support when you're coming up with this plan and you're working to implement it, or if you're running into challenges or barriers, or sometimes for some people just having an app means that you get like the push notification reminder to do something.
Sure.
And so that was the other part, again, thinking about how is this easy to implement in practice. You can explain these things in a broad way, and then you've got these extra tools that are right there on the backside to be able to go into more detail for patients and families.
Yeah. And again, it's not to replace the benefits of medication or therapy. It's really a way to guide yourself through your treatment and give you other options. But just wanted to stress that there's still, enormous benefit in those interventions.
Mm-hmm.
Absolutely. Well, I want to thank both of you for being here today. This was, I think, a wonderful and maybe not what people expected when they opened up this podcast, which is great. I think that's wonderful to be able to focus on not always using medicine, but what are these, as we discussed in it, the cornerstone of pediatric treatment, which is preventative therapy, and I think that's what we did today. So it was great to have you here and to share your expertise and all the wonderful data that Dr. Krantz shared as well.
Love the data.
Yeah.
I love it too. It's
don't
just nice
we
that
all?
we've got our
We're working together a lot.
Exactly.
The expertise is great, right? It's kind of all comes together, and I think makes this such a good topic. So thank you very much for joining us.
Thank you. Thanks for having us.
Yes.